Welcome, Howard County community. We are the Oynx Medical Society. This is the Oynx Medical Society Black Health Workshop, where I'll be leading a candid discussion about Black health and equity. This was organized by Dr. Chashana Kindred, who's the president of our society. Here you have Renee Stokes, um, a psychiatrist, uh, Dr. Carmen Fulton, another psychiatrist, myself, a physical medicine rehabilitation doctor. We're going to start with presentations respectively, and afterwards we'll have an open conversation about Black health and equity, if there are any questions. So we're going to start with Dr. Carmen Fulton. Dr. Carmen Fulton received her medical degree from the University of Maryland School of Medicine. She also has a master's in public health from Johns Hopkins University. She is currently employed as an inpatient psychiatrist at Clifton T. Perkins Hospital Center in Jessup, Maryland. Her presentation is Suffering in Silence, Depression in Black Men. Dr. Fulton, it's all you.
Okay, thank you so much for that introduction. Give me 1 second so I can open up my PowerPoint. Okay, let me see. Is everybody able to see my presentation so far?
Yes.
Okay, perfect. So again, the title of my presentation is Suffering in Silence, Depression in Black Men. And just to start off a little bit about depression in general, it is the leading cause of disability worldwide and is a major contributor to the overall global burden of disease. Since the pandemic, studies have shown it has increased from about 4% of the population to 25% of the population globally. So it is a huge issue. Before the pandemic, when they measured rates of depression among Black men, it was about 5 to 10% over their lifetime. Since the pandemic, there hasn't been any new research, so I imagine that that's also increased just as it's increased for the global population. Depression is important because at its worst, it can lead to suicide. In the United States alone, over 700,000 people die of suicide each year. It is the fourth leading cause of death in 15 to 29-year-olds. So it is an important topic to address, especially among Black men, where it has been kind of underreported and not spoken about as much as it needs to be. So symptoms of depression, there are two kind of cardinal symptoms of depression, and you have to have one of these two in order to be diagnosed with major depressive disorder. The first one is having a depressed mood, either feeling sad, irritable, or empty inside. The second symptom that you have to have, it's either or, is a loss of pleasure or interest in activities. And these symptoms have to occur most of the day, nearly every day, for at least 2 weeks. In addition to one of these two symptoms, people will also have 4 or more of the following symptoms: poor concentration or just decreased focus, changes in appetite or weight. People will either overeat or undereat, and their weight will reflect that. They'll either gain weight or lose weight. Feelings of excessive guilt or low self-worth, feeling especially tired or low in energy, a general hopelessness about the future, not believing that things can get any better, disrupted sleep, so either sleeping too much or too little, and most commonly it's sleeping too little, and then thoughts about dying or suicide. So what causes depression? It's really a mix of several different factors. The first one being biological. So oftentimes people will either not produce enough neurotransmitters, and it tends to happen genetically, through families not creating enough of the neurotransmitters that make us feel happy, or more commonly, overusing the neurotransmitters, kind of getting rid of them too quickly for them to stay around and make us feel kind of happy and content. The second thing is psychological factors. Sometimes when people believe that they don't have any control over their life or any control over any negative circumstances that happen to them, they tend to be more depressed. And if they believe that they kind of deserve negative events to happen to them, or how they attribute what happens to them, also is a psychological factor that can lead to depression. And then finally, socially, just adverse life events, just bad things happening to us can lead to depression. And then that plus the lack of social support, when we do not feel that we are supported by our friends or our family members, that we have anybody to lean on, those things can lead to depression as well. So is depression any different in Blacks than it is in whites or other groups? And the symptoms of depression may be the same experience, but what is disproportionate is that Black people tend to be disproportionately overexposed to psychological stressors that can lead to depression. So that can be unemployment, racism, and violence. When Blacks suffer from depression, they're more likely to be disabled by it. And then finally, when Blacks suffer from depression, they are likely to experience the symptoms over a longer period of time, or they're more chronic than in white counterparts. So why is addressing depression in Black men so important? Well, the Black family unit is directly impacted by the emotional health of Black men. When a man is ill, it is difficult for him to fulfill the expected obligations to his family and others in his social network. And a lot of times he's the base of the family. So if he's experiencing depression, it really bleeds into the rest of the family and the social networks that he's involved with. So there are certain risk factors for depression in Black men, 3 of which are more significant or have been more consistent across studies. But age plays a role. Ages 15 to 29, as I mentioned, is a key age where depression may be worse, tends to get better over time for Black men as they age. Conflict between the sexes. So people who are separated, widowed, divorced, or single are actually more likely to be depressed than a person who's married. Employment status. And this is common in all demographics, but people who are unemployed are more likely to be depressed than people who are employed. Economic status and income. And this is especially true for Black men. Making sure that they are making good money, that they can support themselves and their family actually helps to decrease the risk of depression. And job security helps to decrease the risk of depression in Black men. Family structure, again, this talks about the social support that we mentioned earlier. Having a family or peers that are being very helpful is important for to prevent depression. Health and illness. People who are suffering from chronic medical illnesses are more likely to be depressed than people who do not have chronic medical illnesses. Psychosocial coping, again, going back to where that belief is about having control over your circumstances or whether or not you deserve negative things to happen to you. Racism and discrimination plays a huge role. And actually in studies, racism, discrimination, psychosocial coping, and economic status and income were the 3 most important factors affecting Black men in depression. Residential mobility and status, where you live matters, especially if it's in a violent neighborhood or an unsafe neighborhood. And then finally, violence and trauma plays a huge role as well, and probably an underrepresented role. I don't think it's been explored enough of how much violence and trauma plays a role in depression with Black men. So that's another area. Protective factors, again, the biggest ones were being married. And interestingly, this is not true for women. This is more true for men, that if they are married, they are happier. Employment, higher job status and job security is what I mentioned earlier, helps Black men, protects them from being depressed. And then having a strong support network makes a difference too. There's certain barriers to getting treatment for Black men that we'll talk about, and I categorize them into the 3 C's. There's a cultural barrier where stigma and perceptions about needing help influence Black men actually asking for treatment. Cognitively, recognizing one even needs help is a huge barrier because recognizing the symptoms of depression may be missed in a lot of Black men. And then competence, making sure that providers actually recognize that Black men are actually experiencing symptoms of depression is an important area that we may be missing or underreporting depression in Black men. I'm going to play this video. I hope you all can hear it.
Can't hear it.
Okay. Okay, so my apologies, but the video is a clip from Antoine Fisher, which is a movie that came out several years ago about a Black man who grew up in a very traumatic childhood and joined the military. And he had a lot of behavioral incidents in the military and actually had to be referred to a psychiatrist. And in this particular clip, he's confronting the people that abused him in his childhood, and he's telling them, I'm still standing, I'm still strong. And this leads into what I refer to as the cultural barriers of a Black man seeking treatment. And really, it's the definition of masculinity. Typically, Black men, or traditionally, I'll say, because times are changing and people are much more aware of a kind of mental health and gender roles are changing. But traditional views of masculinity, especially in Black culture, was that Black men couldn't cry, right? They had to be strong. They had to be the rock for the family. And so a lot of times Black men have a hard time expressing a depressed affect or expressing tearfulness because they're brought up to not be vulnerable. A lot of times it's looked at being vulnerable as a perception of weakness, or a person has too much pride to show that part of themselves. And then another area that traditionally has been an issue is that what happens at home stays at home. So there was this resistance to outside help because you don't want outside providers being in your family business, right? And so a lot of times Black men are just kind of raised to hold everything inside. There's cognitive barriers. Again, because traditionally Black men have been raised to be more stoic and have restricted emotions and not be able to cry. Oftentimes they don't recognize that, they may be depressed because they're complaining that they have this inability to cry, right? So if they're not crying, they feel like they're not depressed. But if you guys remember, some of the key factors to having depressed mood earlier were also irritability and just feeling distant. And so Black men are actually more likely to show irritability or anger, more like what we call externalizing behaviors. They're more likely to show those kind of symptoms than to show tearfulness. Frequently, Black men believe that they're supposed to feel this way, that life is just naturally stressful and stressful for them being a Black man in America, and so that this is normal when it's not actually normal. And they're less likely to recognize symptoms unless they are severe. And then lastly, competence. So providers matter, right? Providers who are kind of culturally competent and recognize some of the ways Black men express depression is really important, because as I mentioned before, sometimes Black men will express depression in an atypical fashion, right? So they may either lash out in anger or irritability. Black men are often likely to express it through substance use as well, kind of suppressing their pain by using substances, and if a provider can't recognize that there's that relationship between the two, they may miss that there's this underlying depression that needs to be treated. And then finally, communicating feelings in a way that healthcare providers may not understand. So if a person is using slang or like common colloquialisms that a provider is not necessarily cognizant of what it means, they may miss out what they're talking about. For example, in Baltimore City, a lot of times patients will use the term zapping out. And zapping out can mean a lot of different things, but typically it means being very angry and kind of losing control of your behavior because you're so angry. And a lot of times providers will misread that as like, oh my God, this person has bipolar disorder and they're becoming manic, as opposed to, no, they're just really angry and irritable because they're depressed or they're traumatized and they don't have another way to express themselves. So a lot of times cultural competence matters as well. So what can we do about it? We have to talk about it. We have to keep the conversation open. The more we speak about it openly, the less stigma there is involved to recognizing that it's an issue and for people getting help. If you see something, say something. Again, sometimes it really takes a person to open the conversation for a man to decide that it's safe space to express themselves. Providing support, just really being non-judgmental. Again, this is can be an assault to a person's belief about their masculinity. And so just providing this love and support to say, we've got your back regardless, go take care of yourself. Like, that's really important. And then finally, getting professional help. Professional help is out there, it's available. So recognizing listen, I've gotten to a point where I need someone else to step in for me, some community resources. When people typically ask me who to refer a person to, I always tell them psychologytoday.com is such a useful website. It has the profiles of the providers. So typically Black men will also look for a provider that looks like them. So you're able to find a provider that looks like you or meets the criteria that you have. You can find somebody who takes your insurance in the area that you're located in. There's all types of filters. So if spirituality is very important to you and you want a spiritual provider, they're available on psychologytoday.com all through the different filters. Finally, Howard County Health Department has a behavioral health section, and the number's listed here if you want to reach out to Howard County. And then I tell everybody, if you have the list of numbers that are important in an emergency, like 911 and poison control, put the National Suicide Prevention Hotline with that list of emergency numbers as well, because that is extremely helpful. And you really never know what people are thinking if you're not talking about it. So National Suicide Prevention Hotline is helpful as well. And then this last slide has some references for some of the data that I included in this presentation. But I think that is it. And I'm willing to take some questions now, or if not, we can move forward.
Thank you, Dr. Fulton. This is very on time, a timely presentation, especially for where we're at now, kind of in society where I think a lot of Black men are becoming more comfortable with looking for this kind of help. Amongst our peer group, it seems to be more of a subject. Have you noted that kind of in your practice, or have you noted that just with your peers that you've seen more Black men kind of recognize themselves that they need help?
I have. I still feel like it's a lot less than it needs to be. I still feel like Black men are very hesitant to seek treatment. Oftentimes when they're seeking treatment, it's because their wife is referring them for treatment, or, kind of using language to let them know, if you don't take care of yourself, then this isn't going to be, a positive relationship moving forward. So sometimes people are, kind of encouraging them to a point where they know that now's the time I need to get this, or I'm going to lose out on something that's important to me. So I'm still seeing a lot of hesitation. And there's a lot of resistance to, certain treatments are very helpful. Medication can be very helpful when depression is severe. Still seeing a lot of resistance to taking medication. So I definitely feel like we have some ways to go. But the conversations are happening a little bit more at home, which I'm happy to hear.
Do you find that when they seek the treatment that they start to be more receptive when the treatment starts?
For those that are receptive, so again, medication can be very helpful when your depression is severe. And sometimes you kind of need that boost in order to move forward and really start to do the positive things that will help you get better. And so when a person takes the medication regularly, I do see that they're making some progress. Like I said, a lot of times people are resistant to doing that, and it's just a bigger hump to try to overcome in order to do the kind of psychological and social things that will, you know, make the depression better too. So I still see a lot of resistance with the medication. And a lot of it has to do with side effects too. You know, medication does come with some side effects that are, for men, it can, for anybody, it can cause sexual side effects. But when you tell a man that, they're particularly scared about taking it. And I always have to remind them, like, sometimes sexual side effects, sexual issues come from being depressed, right? So, you know, once you start taking medication and you feel better, sometimes your sex life actually gets better, you know? So I try to tell people not to be so resistant to that. But when people really follow through with the treatment recommendations, yes, I see a significant difference, and they're happy that they did it.
Great. Well, thank you so much. Thank you. We're going to continue on the mental health education with Dr. Renee Stokes. Dr. Stokes is a board certified adult child psychiatrist with many years of experience in treating psychiatric disorders in both adults and children in the outpatient setting. Dr. Stokes has specific interests in trauma focused psychiatric care, mental health disparities in psychiatric care through the developmental lens. Most recently, Dr. Stokes operates Child Psych on Call, where she collaborates with pediatricians, providing stopgap psychiatric care and maintains a small clinical practice. Dr. Stokes will be presenting Coping in Chaos. Let's talk about it. Dr. Stokes.
Good morning, everyone. I just want to start by saying that I'm delighted to join with you all today for such a timely message around depression. And if you all can confirm that you can see my slides, I'll go ahead and get started. Are you able to see my slides?
No, not quite.
Let's see. Hmm.
Oh, there we go.
Are you able to see my screen now?
Yeah, I see the MLK Day of Service.
Okay, just one moment. Okay, are you able to see the Keynote
Yes.
app currently? Okay, perfect. Thanks for bearing with me through those technical challenges. So my name's Dr. Renee Stokes. I am delighted to share with you all this morning about topics that are near and dear to me, both, you know, personally and professionally, and that's about mental health, in particular, taking a closer look at how it's impacting families in light of all the changes that we're enduring related to the COVID-19 epidemic. And so for my slide deck today, we're talking about coping in chaos. To begin, let's start first by going back in time, sort of the good old days, life pre-COVID, where we didn't have to wear a mask and we were able to gather freely. And let's take a look at the family structure back then. Many families were still quite subject to the grind and sort of held together by a well-orchestrated village of supports, whether it included schools, extended family, before care, after care, community resources, special educators. And so while life was certainly more free than we are at this time, many of our families were propped up by a pretty intricate support system. And then we have sort of the straw that broke the camel's back, or really the event that exposed how tenuous some of our families were set up to be. And so we have families that were initially abruptly separated from their support systems. We have families tasked with the sort of impossibility of working while simultaneously facilitating their kids' education. We have families with children with special needs who were sort of cut off from all of the supports that made that care in the community possible for their child. And then we have teens, especially, who were cut off rather abruptly from some of the positive opportunities for social interaction that occur in our schools, sometimes facilitated through sports or other extracurricular activities. And so we have a pretty big blow that was dealt to us all back in 2020, and now we're sort of picking up the pieces slowly. And so youth and families everywhere are really feeling the impact and the pressure of the situation. So I think with that said, it's important to then sort of drill down deeper to communities of color. One thing that we do know for sure, according to data from the US Bureau of Labor Statistics, is that in the time pre-COVID to within the pandemic, the rates of joblessness have increased almost threefold in communities of color as compared to a much lower increase in non-color communities. And so I think it's important for us to consider what that does to families that are trying to absorb the impact of this COVID-19 epidemic. And so certainly alongside increased joblessness, we see changes in health insurance status that can lead to delays in care. Certainly, many families already had rather tenuous financial situations, and so that can influence housing status, certainly can contribute to food insecurity. And then there's an added element of grief, wherein many families of color were more likely rather to experience the death of a loved one related to COVID. And so I think it's important to sort of impart that lens on families that are attempting to cope with COVID-19 and the impact of those stresses. And furthermore, Dr. Fulton referenced that we're all aware that our country has a history that's fairly difficult when it comes to equity and race and racism. And I think the increased visibility over the last few years has really prompted a lot more conversation with youth around that historical difficulty. And I know that many youth, both of color and and Caucasian youth, are having to process all of these moments on top of everything else that they're grappling with in this pandemic. So it seems appropriate to first start with what can we all do, because we all are significantly impacted by this epidemic. And so there's sort of the things that we can do to optimize our body's ability to maintain mood and to cope with stresses. And so these are the things we can aim to optimize in terms of sleep and optimizing nutrition. There's been studies that have been done that show that time outside for kids is very helpful when it comes to building attention, managing mood and outburst. And exercise certainly goes right alongside that. And then also the epidemic, I think, has brought about a new emphasis on building familial capacity, so how connected we are within our families. And so that really gives us an opportunity to create new family traditions, finding ways to connect with family and others virtually for whom we may not be able to gather with in person. And then the other thing that we can all do is to ensure that we still try to get our usual medical care. One, to identify any whether it be hormonal or vitamin levels or other medical issues that can contribute to depression and anxiety, and ensure that there's no delays to treatment for any other potential medical issues. But what if it's not just the COVID stress? And how can I ensure that I am looking for to answer that question when it comes to my child? So first, it could be depression. And so at the most basic level, as Dr. Fulton mentioned, depression is a very treatable medical illness that can impact both your body and your mind. And a lot of sort of the key features that we look for are highlighted here on this particular slide. There's certainly a lifetime likelihood of having depression that we think, and studies tend to reiterate that that is likely underreported in communities of color related to some of the stigma and perceived inadequacies related to saying, hey, I have depression. And then one thing that is important to note that youth, especially adolescents, instead of sullen or sad mood, are more likely to demonstrate irritability. When I tell parents that, a lot of times they say, "Oh, well, all teens are irritable," and that may be there may be some amount of increase in irritability when kids reach adolescence. It's important to sort of meter that observation and couple it with other changes that could be indicative of an actual episode of depression. Or could your kid be dealing with an anxiety disorder? This one is, there's certainly a number of diagnoses that fall under the anxiety umbrella. So certainly there can be panic episodes, there can be sort of generalized worries or even worries that reach sort of an obsessive level. And a lot of times kids or teens may not have sort of the words to specifically say anxiety, but they may say they can't sleep at night, or they may say that they can't concentrate because they're constantly focused on worries, or they may have outright panic attacks, may not use that language, but may describe lots of feelings in their body, including racing heart, feeling like something bad is about to happen, not being able to catch their breath. And then certainly trauma can create anxiety-like symptoms. So pretty much any situation that compromises a person's sense of safety can provoke a trauma reaction. And what that means is that there's sort of a saying that when it comes to trauma, the body keeps the score. And so in a traumatic situation where a person's safety has been compromised, they have appropriate activation of their fight or flight system. But then in subsequent moments, even when they're no longer in an unsafe situation, they can then have sort of inappropriate activation of that fight or flight system. And that's where things that are related to that previous trauma event can provoke the same level of fear, the same level of dread, the same level of panic, and sense of helplessness. And then I think we also have to check in around the extent of coping with the potential for catching COVID. So a lot of kids have varying levels of understanding for what their risk is. And so we have to check in to see if those are becoming outsized in proportion to their ability to kind of carry on with their daily functioning. So what do we do if we're concerned about our child? And so step one, and it's an old adage that you can't pour from an empty cup. Step one is to check in on how you're coping as a parent, as a caregiver, as a member of any child's village. It's going to be difficult for us to support our children if we're in a place where we're not whole enough to sort of be ready to support them. And so I always recommend to parents, like they do on the airplanes, you can't help anyone else with their mask until you check in on yours. And so a lot of times the first step to getting your child the care that they need, or even assessing if they need care, is to find the appropriate level of support as a parent. And then step two would be to check in with your child. And that includes a couple of different steps. The first thing is just to sort of bear witness to your child, to watch their behaviors, look out for any changes in their attitude and the level of isolation, the way they're eating, the way they respond to things that previously they enjoyed. And I think that will really inform sort of how you can interpret their responses to any subsequent conversations. Then, of course, next is to have that conversation to check in with your child. I think it's really important that families always remember to ensure that those moments are not in a task-oriented moment. So finding a quiet moment that's not in the middle of getting them up for school or getting them down for bed or getting them through their homework. And certainly you don't want to attempt this conversation in earnest in the middle of any arguments or disciplinary actions or things like that. And then to facilitate a conversation, you really want to start with open-ended questions and sort of assume impact of the COVID pandemic rather, and say, what's been the hardest part for you? And then you can say, tell me about times that you've been down on a regular basis. And they may say, no, that's not been an issue for me. They may say, things have been fine, but I think it's easier to open with sort of normalizing that there's been some impact with this new normal of ours, and then let them sort of tell you what their experience has been. And then the next thing, I think, in order to keep the conversation going is to not, to resist sort of the urge to pack them up and say, oh, don't worry, it'll be over, we're all struggling, because that really can shut down important information that would really inform the best next steps. So it's really important to empathize and validate, to keep the words flowing from your child. And then it's important to ask about suicide. A lot of parents and caregivers are worried or scared to bring up that word, as if just speaking it might encourage it in some fashion. But I think it's like Dr. Fulton mentioned, it's like poison control. It's better to mention it and get a negative response than to never mention it and wish you had. And I think that in this instance, it's pretty straightforward to ask, have things ever gotten so bad that you didn't see a way forward or wanted to end your life? And then they can really talk about how they're doing in this moment and any previous moments that you may not have known about. And then step 3, after that check-in, if you have no concerns, it's then most important to continue the conversation and try to find times that are one, just times to build connectedness. That usually sort of builds up the bank for these inquiries that we hope to make of our kids. And then to have a set time to check in, whether it be weekly, whether it be 5 minutes we can quietly take away from the rest of the family. And then, but if you are concerned after that check-in, that's when I think it's time to consider a formal psychiatric evaluation, either by a talk therapist or a psychiatrist. And if you're concerned about an affirmative response to a suicide inquiry, you would certainly want to move toward an emergency psychiatric evaluation. So that's something that can be facilitated through emergency rooms. Certainly you can reach out to the suicide hotline, as Dr. Fulton mentioned, where they can sort of facilitate or direct the best next steps. And then in some cases, you're able to get a next day appointment if that's indicated. But you always, again, want to err on the side of more support rather than less support in those moments that can be quite challenging. And then, so what's next if you do need to get care and don't have a positive suicide response to manage? So a lot of times people can be limited by which providers are covered by their insurance. There are moves to have parity or equity in care between somatic or medical illness and psychiatric care through health insurance providers, but it's not exactly there yet. And so there may be a limited list of providers. So you want to check with your health insurance provider to see who's covered. And then you want to schedule that initial evaluation. A psychotherapist is a person who can render sort of the talk therapy that we understand. That can be done even with kids in preschool through play therapy on up to your adolescence. And then the psychiatrists, some are able to provide the psychotherapy or talk therapy, but if medications are indicated, they'll be your point person for that. And the good news is to know that the majority of youth who experience the first episode of depression or anxiety won't go on to have chronic mental illness as adults with initial treatment and therapy. And so Dr. Fulton did touch on some of the barriers that get in the way. And I think some of the nuance that comes with getting a kid to care is that how it can make the parent feel. There can certainly be those layers around. We keep what's our business. What if people find out? Concerns around confidentiality. But also some parents have concerns that this will impact their ability to join the military, or if this will show up on their job applications at later points in life. And so can be certainly hesitation around, am I compromising some future opportunities by getting my child the care that they need rather. And so looking forward, I do think that families on the whole are through this sort of abrupt reset moment, just sort of taking inventory of their family's capacity and taking a closer look at maybe we do need to shift things, or is this a point where we should sort of renegotiate some of the family supports, or how do we keep some of the new opportunities for support that we've been able to sort of arrive at through the limitations of the pandemic? And then what do we want to do differently looking forward? And I think these are sort of conversations that every family can have in light of all the changes that we've had to absorb over the past almost 2 years. And so yes, let's talk about it. All families are feeling and absorbing this impact. How's your family coping? How has the coping changed since the pandemic? And any other questions you might have, I'm happy to answer.
Hey, Dr. Stokes, thank you for this presentation. It's definitely on time. Um, how young should a parent be concerned about their kid maybe being affected by these kinds of stressors?
So when it comes to children, they are sort of creatures of habit. And so their ability to go about their day, to meet their developmental milestones, all hinges on sort of a backbone of routine that's fairly consistent. And so to that end, I believe that all kiddos are impacted, whether it be preschool and no longer going to daycare in the same fashion that it had been previously, having to absorb wearing a mask, straight on up to our adolescents for whom peer interaction is of increasing value, and they don't have access to peers in the usual ways, and sometimes tend to have an outsized amount of access to peers in ways that are less healthy, like social media and what have you. And so I would say there's no age that's young enough, that's too young for assessing impact of this new normal. And certainly those would be age appropriate conversations. So you can ask, 3-year-olds if they know why they have to wear a mask, and if they have questions about the sickness, or some people call it COVID, or some people call it the sickness in their household. And then you can assess if they ever have thoughts that they don't want about the sickness or about wearing masks. And for younger kids, a lot of times what they can't say with words, they say with their behaviors. And so much of your inquiry will be informed by what you see in terms of behavioral changes. And whereas kids get older, certainly you can have more of the conversation to make that assessment. But I think it's worthwhile to sort of make that inquiry for all of our kids, and really for all of our caregivers as well.
what would be the threshold for, say, like maybe a 4 to 8 year old? When is it time to take them to someone to get help?
Yeah, it's a great question. And so I do think, and then again, going back to Dr. Fulton's conversation around normalizing the experience of sadness sort of as part of the continue, or the spectrum rather, of human emotion. And so I think it's important to make inquiries about sadness when it comes to concerns around depression, and know that being sad on a day is not necessarily cause for concern. But certainly, if you have a child who is consistently depressed over time, and in psychiatry, we sort of look at enduring changes at least 2 weeks of a consistent experience as something that's noteworthy. And if you sometimes you can attach that to a known stressor, and then you can sort of try to understand, are we trending sort of out of processing that stressor or not? But I think if you are concerned, certainly you can always start with a conversation with your pediatrician, like, hey, is this outside of the range of what I should expect? And if it is, certainly they'll be useful in facilitating the next steps and referring to a mental health provider for further assessment.
Well, thank you. Thank you so much. Thank you. Um, yes, I have the last presentation. Um, my name is Jared Reeves. I'm a board certified physical medicine rehabilitation physician. I received my medical degree from the University of Maryland School of Medicine, and I did my surgical internship at Union Memorial Hospital and my PM&R residency at Eastern Virginia Medical School. Currently the clinical director of the University of Maryland Capital Region Function and Mobility Clinic and the medical director of Health IT and Informatics for the University of Maryland Capital Region Medical System. My presentation will be it'll be a change of pace, more of a daily annoyance or a, you know, debilitator, but it'll be understanding lower back pain. I'm going to share my screen right now. Y'all see this presentation?
Yeah.
Can everyone see? Good, good. Got it. So understanding back pain, lower back pain. The objectives are to discuss the common causes of low back pain, discuss the risk factors that can lead to low back pain, discuss treatments and prevention. So low back pain is a very common experience amongst people. It's more of a symptom than an actual disease. 40% of people state they've had low back pain in the past 6 months. 80% of people will experience low back pain in their lifetime. Most episodes resolve without treatment. And when I say low back pain, when I say 80% of people will experience it, it's not always I got to go to the hospital or I have to sit down forever. Sometimes you might pull your back, moving a couch and it goes away in a day. And that's kind of what we're talking about. It doesn't have to be the big event that some people equate with back pain. So there are three common causes. Most back pain comes from one of these three issues: overuse injury of the muscles, like sprains and strains, osteoarthritis, or herniated disc. And those are three kind of very different reasons for back pain happening. So let's talk about lumbar sprains and strains. The common ages are 20 to 40. The location of the pain is usually the low back pain, buttock, back of the thighs. Type of the pain is achy spasm. Um, it gets worse with activity or bending, and it tends to improve with rest. I added the pictures because sometimes you don't always understand the strain versus sprain. A strain is usually a damage in the muscle, and a sprain is a damage in the ligament. Either way, these are kind of local problems that don't radiate down the leg. So usually I'm asking, is this back pain? Does it go all the way? Does it go anywhere other than your back, or is it kind of staying local in the back? They say staying local in the back. I tend to think of this as low back pain. Risk factors: poor conditioning or obesity, smoking, which reduces the health of the tissues, so they're easier to damage if you smoke. And then proper lifting technique. People say lift with your legs, not with your back. They're just trying to explain to you, lift correctly. Don't put so much strain on your back that you can actually damage the tissue. So treatment, rest, chill out, sit down, relax, whatever you were doing, stop doing if you can. And usually about 1 to 3 days. In that time period, medications like anti-inflammatory medications or prescribed muscle relaxers can help with the pain and spasms. If it's not going away, physical therapy for strengthening, stretching, and conditioning. You'll see physical therapy come up a lot because usually it's the only real cure to any back pain. When I say curing, like, actually abating the back pain to the point where it's not a common barrier to function. Prognosis. The prognosis for sprains and strains are excellent for a complete recovery. More than 90% of the patients completely recover within 1 month. So the strains and sprains can heal and the back pain tends to go away completely. We're going to move on to the herniated disc, also known as slip disc or ruptured discs. When people say those two terms, they mean herniated discs. So what happens is when the disc gets damaged, it puts pressure on spinal nerves, which cause pain, numbness and tingling, or weakness in one or both legs. So not just pain in your back, a lot of times pain that shoots down your leg. Common ages for this are 30 to 50, the location of the pain, lower back to the lower leg, types of pain, sharp shooting or burning pain down the leg. The pain tends to decrease with standing, so and it increases with bending. So you can kind of help the pain go away by standing, and that's going to be one of the patterns you see. So things that lead to a disc that weakens and is more likely to herniate, just like the sprains and strains, improper lifting technique, smoking, excessive body weight that kind of changes the way your posture works. So you're always putting pressure on certain areas, sudden pressure like lifting, and repetitive strenuous activities. So people who do a lot of work that requires bending. So sciatica is one of the big, so when I talked about pain going down your leg, sciatica is what we're talking about. You hear people using sciatica a lot. It just doesn't mean back pain. Usually it's a very common symptom. It's pain that shoots down behind your leg along the sciatic nerve. So your sciatic nerve comes out here and it goes behind your leg. It's caused by the pressure on the spinal nerve from that sciatic nerve. So usually your nerve roots in your back, that herniated disc can lay on that nerve and irritate it, causing pain. You have tingling that we talked about before, burning pain at the center of your back region, different from just the achy local pain, sometimes weakness in one leg. If there's a loss of bladder or bowel control with weakness in the legs, it's time to seek medical attention. So if you have a back pain and you can't control your bowel or bladder, go to the ER because that's a medical emergency. That means that you're having a stenosis. That's a very serious one. So treatment, non-surgical for 90% of the patients, just like sprains and strains, rest, muscle relaxers, and anti-inflammatory medications. Cold compress and ice packs can be applied several times a day, no more than 20 minutes at a time. So especially when it's brand new, you can kind of gain a little bit of relief with cold. After the spasms are resolved, then you go to heat. So you're not usually doing heat and cold on the same day. You start with cold and then heat comes later after the spasms get better, which means you're kind of in a later part of your damage. Physical therapy, like we talked about before. On epidural injections, they can improve inflammation of the nerve. And those are injections that go into your back and usually is a mix of steroid and like a pain medication like lidocaine. And that can bathe the nerve in a medication that results in less inflammation and less pain. Surgical treatment. only if conservative treatment fails. So surgical treatment is if the things that we try with physical therapy and injections don't work, we'll consider surgical treatment. It's no guarantee that surgery will improve the pain. It's something that you try, but there's no guarantee. Back and leg pain limits normal activity or impair your quality of life. When your life is kind of negatively affected by the pain, you can't work and you can't kind of do the things you usually enjoy, despite trying to do the physical therapy and the more conservative matters. That's when you consider surgery. Um, Again, if you have a loss of normal bowel and bladder function, you go straight to the ED and they'll probably put you into emergency surgery to make sure that no permanent damage happens. You also consider surgery if you're in good health and can tolerate the surgery. So we're going to the next mode of back pain, which is lumbar spondylosis. That's just a big word for arthritis of the spine. Like you get arthritis in your knees or hips or shoulders, you can get arthritis in the spine because you have joints there too. It's a degenerative disease that causes loss of normal spinal function. Aging is a primary cause because degeneration of your bones is normal, it just goes with getting older, and that's kind of how tissue works. It doesn't have to degenerate fast, but there is some degenerate. Like I always tell patients all the time, well, yeah, 15-year-old back and a 55-year-old's backs generally don't look the same, and that's okay. That's kind of how it's supposed to be. You know, the same entity. It doesn't mean that you'll always get pain. It's just normal. Um, Aging is a primary cause. It involves intervertebral discs in the joints of the lumbar spine, leading to all the things you hear about from arthritis, bone spurs. It'll sound like you're talking about your knee. We'll talk about bone spurs and degeneration. The disc can also get degenerated, and those changes can result in pinched nerves and spinal stenosis. So, like, your spinal cord, which controls, the sensory and motor in your arms and legs, runs through the spinal cord. So with arthritis, you can get you can get a little bit of crowding on the spinal cord, and that can result in weakness or changes in how your body feels, or you can result in weakness also. So the age of liver spondylosis is usually over the age of 50. Location of the pain is low back to the lower leg, often both legs. Type of pain, aches, shooting pain, sometimes pins and needles when it's going down the leg when you have the nerve being irritated. Pain increases when walking up a hill and decreases when you're sitting down. You're kind of giving more rest. Risk factors. The cause of osteoarthritis is largely unknown, but age is a big one. Hereditary, sometimes the way people's bodies respond to aging just varies from family to family. Being overweight doesn't help things because you're putting more of a load on your joints and kind of making them do more work. Actual joint injury, like being in a car accident or injuring your joint. Nerve injury, because the way your nerves are able to kind of perceive where your back is can negatively affect these things. Repeated overuse of specific joints. So a lot of plumbers or electricians who have awkward back movements a lot can develop the degeneration a little bit faster. And also lack of physical activity. People who aren't active just don't get the use out of their body. So it's overuse injury, but it's also underuse can kind of speed things up if you because you can cause damage when you use it. So just kind of a constant fitness level can kind of help things go a little slower. The big signs and symptoms are pain and stiffness in the low back, weakness or numbness in one or both legs, pain or morning stiffness that lasts for about 30 minutes after waking up. The pain worsens throughout the day due to activity and limits motion. Treatment. You can't do much to reverse the degeneration of the spondylosis. There are some new treatments coming on, but we're not going to talk about that because there's not a whole lot of research on them just yet. Treatment targets the actual pain that causes spondylosis. like we said before, Motrin, physical therapy, improving your flexibility and strength, and sometimes lumbar injections. Surgical treatment, uncommon. It's indicated that there's severe spinal stenosis, meaning that you have a lot of nerve involvement, a lot of pain that's secondary to the um, spinal cord being crowded in your column, resulting in weakness, or the nerves that leave the spinal cord from the side. Those can cause a lot of pain. So those are just always happening. Sometimes we consider back pain only if it conservative treatment fails. Like with any surgery, age, overall health are taken into consideration. It's also not guaranteed to fix the pain at all. Some people get back pain, get surgery, and it can fix it all the way. Some people get it and it doesn't change anything. So it's a risk and it can't be guaranteed. Prognosis is usually favorable. People learn how to live with it. A lot of people with spondylosis actually don't have any symptoms and will never know that they even had it. Um, Most people who develop back pain improve in a few weeks of the symptoms. It will kind of come and go. People say, I'm having a back pain flare up. That's kind of what they're talking about. And usually, beginning in physical therapy, improving the way your back works, your posture can help a lot. Uh, Very few people go on to develop chronic back pain due to spondylosis. I see them, but I don't think like usually other people don't. So, when the diagnosis, and goes for back pain in general, you don't always need imaging to rule out other problems. So when you go to the doctor and say, I need an MRI, which happens a lot, you don't need an MRI most of the time. The difference between an MRI and an X-ray is, the X-ray looks at the bone, the MRI looks at the spinal cord and the nerves. Um, if your doctor sees back pain enough, they'll have a good idea of which one it is, and you want to get imaging to help guide the treatment. And so when you start, if you come in with a strain, the X-ray will be completely negative. There'll be nothing there, because it's just the bone. Even an MRI a lot of times will be negative because the damage is just not severe enough to show up there. And so you usually start the treatment without a lot of imaging, and then if things don't get much better, then we're going to start getting imaging to help drive how we treat you. Prevention. So the things you can do to kind of stave this stuff off: do exercise to provide more pain for spine stability, uh, lift correctly with good moving techniques like squatting to lift a heavy object. Don't bend and lift, and always get help if you need to. Maintain correct posture when you're sitting and standing. If you smoke, quit. Avoid stressful situations that can cause increased muscle tension. Maintain as healthy of a weight as possible. Extra weight can put a strain on your lower back also. It can change the way, like I said, your posture works and put more stress there and be more painful. And that's it. Here are some of my sources. Okay. Any questions or anything?
I do have a couple questions, Dr. Reeves. As far as exercises to help maintain back stability, what exercises do you recommend?
So a lot of people say, abdominal exercises, and they aren't always specific. So like we don't like a lot of like actual sit-ups because it asks your abdominal region to do a lot of moving. Um, Usually I tell people just some nightly planks. If you've ever seen planks, planks are kind of when you kind of just have your you don't have to start off with the advanced one. Sometimes you might have your knees on the ground and hold yourself up with your elbows and arms, and not on your hands, just on your elbows. And then you can move to having your toes out. You're trying to maintain a straight level between your back, heel, and your shoulders. And at first you might be able to do 5 or 10 seconds, and that's fine. But after a bit of time, you're working your lower back as well as your abdomen to help become like a system. So I tell people, like when folks wear, have you ever seen people wear weight belts or support braces? You're kind of creating a very stable column between your back and your abdomen, and your back and abdomen can do it themselves without those belts. And things like planks are a good thing. Also, just keeping good posture in general. If you're sitting down in a chair, don't always rely on the back cushion. Just kind of sit at kind of perfect straight posture, and you might feel your abdominal region doing a little bit more work, but it's kind of good work. It's not heavy work. It's good work that allows your um, body to learn good posture, and that good posture helps prevent back pain.
And then my second question was, how long do steroid injections last in order to decrease back pain? And then how often, I mean, I know you mentioned physical therapy is probably the best treatment for any of these types of back pain, but what is the limit for steroid injections? How long do they last, and what's the limit of getting steroid injections?
It varies from person to person and the skill of the physician doing it. Um, what I love to see is someone who comes in with a herniated disc, and what happens, you give the steroid injection, they start getting some relief because the steroid is starting to work on their back. And what happens as the disc heals and everything heals, the pain just goes away. It's a one-shot thing. So it gives time for everything else to heal. In that meantime, you aren't hurting as much. So that's like a best case scenario where it's only one and you don't have to do it again probably. What I see more often in my pain colleagues who do them consistently, someone who has like spondylosis or like who had an accident, who has I call a messy back, a complicated back that's just going to always be inflamed because of just the pathology there, and that is not a normally structured back. Um, they tend to be on regimens of epidural steroid injection, usually every 3 to 4 months, so 3 or 4 times a year. 3 or 4 times a year. It's very important that you go to like I'd send my people to certified pain physicians who aren't going to always do the same injection because depending on the problem, there are at least, just off the top of my head, 6 different like back injections you can use. Some folks will do the same one to try to address every problem, and if it doesn't work, it's usually because of that. Like they're doing a transverse injection for a I don't know, for a Z joint. So like you're not even shooting the injection into the right place, but you're just doing the only injection you know how to do, and that can sometimes result in a frequent failure. So you want someone who's going to evaluate you, get a good idea of where your pain is, and do the appropriate intervention for that pain.
Thank
Yeah,
you. Thank you.
no problem.
I just had one question, kind of a personal interest as well. You did
Mhm.
comment around maintaining appropriate posture when we are sitting.
Yes.
And I would love to hear from you. Sometimes sitting gets a bad rap. Can you speak to that and what sort of the layperson should bear in mind or not bear in mind when it comes to how much we sit and how we sit?
Exactly. That's important. Um, it's tough because your average desk and chair aren't really built to sit correctly. But as I tell people, the rules of 90. You want your knees to be at 90 degrees, feet flat on the ground. You want your elbows to be at 90 degrees, your hands to like if you're typing, you want them to kind of drop forward, not be angled too far up, or be at neutral as much as possible. And when you're looking at a computer or looking at what you're doing, you want to be looking straight, not up, not down, straight. And when you do all that, your back will kind of be at a natural, you're gonna place your back at a very optimal position. If you try right now, you'll probably feel your body align. If you get your feet flat on the ground, your knees at 90, your elbows at 90, and you look straight ahead, you'll feel everything. So your head will be above your bottom, and you'll feel the posture change. And that is kind of that ergonomics helps prevent a lot of kind of accidental overuse, which happens at work.
That's super helpful. Thank you.
No problem. Yeah. Thank you, guys. Thanks, everyone. Um, I don't know if we have any population to talk about health equity. But I don't know if Miss Howe is still here. I think we're done. I want to thank Dr. Fulton, Dr. Stokes, and Dr. Kendrick for setting everything up and being available to present. And thank you, Howard County, for inviting us and allowing us to serve our community in this way. Thank you very much.
Thank you so much for joining this. If anyone was to watch this later and they wanted to get in touch with any of you, is there like an email address, a central email address that somebody could contact you with any questions or anything?
Yes, probably the best email address to reach any of us is the email address we use for Oynx Medical Society. And for the purpose of today, we can use the new member at onyxmedicalsociety.com. And so that's new, N-E-W, member, M-E-M-B-E-R, the @ and then Oynx, O-N-Y-X, medical, M-E-D-I-C-A-L, society, SOCIETY.com. Probably would be the best email to reach all of us at, and then I can direct it towards who the question is for.
Okay, great. Thank you everyone for joining us today on MLK Day.
Thank you very much.
Thanks for having
Thanks
us.
for having me.
You're welcome. Have a good day, y'all.
All right.
All right, bye guys.
Bye.